Good morning, respected R.C. Gupta sir, Dangai sir, Raman sir, or Dr. Sanjay Singhal sir. In the series of in the PGCR series, today is the 7th PGCR, that is on the approach of fever. So you know, एक वो washing powder का ad है ना कि दाग अच्छे होते हैं. So this fever is sometimes good. It is an early warning that something is going on in the body, and if fever is not there, something bad is there. Either the patient is immunocompromised, or patient is having some chronic illness, or in elderly or in diabetics. So fever है तो अच्छा है, but at times when fever exceeds its limits, then it can harm your body also. So to discuss physiology and other things and then approach to fever, we have planned a PGCR. Now I like to invite the chairperson for today's PGCR, Dr. Raman Sharma sir, Professor General Medicine, and Dr. Sanjay Singhal sir, Professor and Head General Surgery Department. The moderators for today PGCR are Dr. Ram from General Medicine and Dr. Anil Pawar from General Medicine. And now I like to invite the Department of Physiology to start the PGCR.
A very good morning to all the dignitaries, faculty, seniors and my colleague. Our today's topic for the PGCR is approach to fever. The flow of presentation is starting with the physiology of fever, coming to the terminologies of fever, patterns and medical causes of fever, different tests that are performed in microbiology and pathology, surgical perspective on fever, light on fever and pregnancy, and approach concluding with the approach to a patient with fever. To understand the topic, we first go through the normal physiological body temperature regulation. All mammals maintain a constant body temperature of about 37 degrees centigrade. Concept of shell versus core temperature. Temperature of limb and surface layer of trunk is the shell temperature. In cold weather, shell temperature decreases the loss of body heat to the environment by conductional radiation. Temperature of deeper tissues like intra-abdominal, intrathoracic, intracranial, esophageal and rectal are considered to be core temperature. In hot environment, shell temperature approaches the core temperature, and this helps in heat loss by conduction and radiation. Normal variations in body temperature, diurnal and seasonal variation, low levels at 8 am and summers and high levels at 4 pm and during winters. Age, it is lowered by 0.02 for every 10-year increase in age. Comorbid conditions like cancer, it is higher 0.02 degrees, and hypothyroidism, it is lower by 0.01 degree centigrade. Menstruation, AM temperature is lower during 2 weeks before ovulation, then rises by 0.6 degrees centigrade with ovulation and then stays at this level till menses. Modalities of heat gain and heat loss. Heat gain modalities are BMR, muscular activity, hormonal changes, thermic effect of food, postural change and environment. Heat loss modalities will be radiation, conduction, convection and evaporation. Why do we need to regulate the temperature? To provide the optimum condition for enzyme catalyzed reactions to be carried out. Temperature above this normal will denature the enzyme and block the metabolic pathways, while temperature below this will slow down the metabolism and affect the brain. Body temperature control. The hypothalamus acts as a thermostat. It receives nerve impulses from heat and cold thermoreceptors in the skin. Free nerve endings in the skin respond to heat and cold relay the senses to the hypothalamus and cerebral cortex. There are also receptors in the hypothalamus called as central thermoreceptors which detect changes in the blood temperature. Body control, body temperature control, heat loss center and heat production center. Neurons in the preoptic region, anterior or rostral hypothalamus, it causes cutaneous vasodilation, sweating, panting, which decreases the heat production. While heat production or conservation center, neurons in the posterior or caudal hypothalamus, which causes vasoconstriction, shivering, which activates the heat production. In this diagram, we can appreciate that due to the anterior hypothalamus, there is vasodilation and cooling effect is done. While due to external factors which causes vasoconstriction, shivering, there is warming. Normal and febrile body temperatures. Normal body temperature is ranging from 98.6 to 100.4. Mild to low grade fever is considered when the temperature is 100.5 to 102.2. Moderate grade fever is termed as when the temperature is between 102.2 to 104. High-grade fever is when the temperature is between 104 to 106, and hyperpyrexia is termed when the temperature raises to 106 degrees. Definition of fever: temperature of more than 37.7 degrees centigrade is termed in 99 percentile of healthy individuals as fever. Elevation of body temperature that exceeds the normal daily variation and occurs in conjunction with an increase in hypothalamic set point is termed to be fever. Fever, there are role of exogenous and endogenous pyrogens. Exogenous pyrogens like bacteria, virus and fungi stimulates the immune cells, which causes the release of IL-6, interferons and TNF factors, while endogenous pyrogens will stimulate the PGE2, elevates the thermoregulatory set point, heat conservation, heat production starts, which causes fever. Correction of overheating, it is detected by thermoreceptors in the hypothalamus, causes vasodilation, sweating. To understand the heat loss modalities, in this picture we can appreciate the work in the contracting muscle which causes conduction, then muscle blood flow which causes convection, and to appreciate the radiation process, reflected solar radiation, ground radiation and sky thermal radiation is there, and evaporation by respiratory and sweating. Thank you. Now I would like to invite Dr. Mahima to discuss on the terminologies of fever from the Department of Medicine.
Good morning, respected teachers, seniors and colleagues. So I'll be discussing the different terms that are being used to describe fever. Coming first is the hyperpyrexia, which is a fever of more than 41.5 degrees centigrade, and it is most common in patients with CNS hemorrhages, mostly the pontine hemorrhages. Next is the hypothalamic fever, which is an elevated temperature caused by abnormal hypothalamic function. There is an elevation in the hypothalamic set point, and it occurs due to the local trauma, hemorrhage, tumor or intrinsic hypothalamic malfunctions. Hyperthermia or the heat stroke, which is defined as the uncontrolled increase in the body temperature that exceeds body's ability to lose heat. It occurs due to the exogenous heat exposure, endogenous heat production, or treatment with the drugs that interfere with the thermoregulation. Setting of the hypothalamic thermoregulatory center is unchanged. In this fever, there are no pyrogenic molecules that are involved, and it does not respond to the antipyretics. It is rapidly fatal and skin is hot yet dry. Such patients present with dizziness, fatigue, tachycardia or tachypnea. Coming next is the factitious fever, which is a fever created by the patient by the manipulation of the thermometer to obtain a medical care. It is uncommon and may relate to a psychiatric illness. On examination of such a patient, the patient looks well. There is absence of temperature related changes in the pulse rate. The temperature also is more than 41 degrees centigrade, and there is absence of sweating. And on laboratory investigation, such patients have normal ESR and CRP despite high-grade fever. Next, I would like to invite Dr. Suchita to describe types and medical causes of fever.
Good morning, respected professors and my dear colleagues. I'll be discussing the patterns of fever and the medical causes of fever. So starting with patterns. All of us have studied various patterns in our MBBS days, so I'd like to ask the audience, what's the definition of a continuous fever?
Fever that does not fluctuate for more than 1 degree within 24 hours and also does not touch the baseline.
Yes, correct. So basically, a continuous fever is one that does not fluctuate by more than 1 degree Celsius during a period of 24 hours, and it does not touch the baseline. Examples are lobar pneumonia and acute bacterial meningitis. Can anyone tell me what remittent fever means? No one? Okay, so remittent fever is very similar to a continuous fever, but there is a fluctuation of more than 1 degree Celsius during the course of the day, but the temperature does not reach the baseline. This is commonly seen in infective endocarditis and typhoid fever. And then we have intermittent or spiking fevers. These are usually associated with chills. So this is a fever that is present only for a few hours at a time before returning to the normal baseline temperature. A very classical example of intermittent fever is malaria. And I think we've all remember the different types of fever patterns that we see in malaria. Quotidian fever is one that occurs daily, caused by Plasmodium knowlesi. Tertian fever, does anyone know what tertian fever means? So this actually occurs every second day. So if the fever is on the first day, then the next spike of the fever is going to be on the third day. This is seen in Plasmodium falciparum and vivax. And quartan fever is one that occurs every third day. So if the first peak is on the first day, the next peak is going to be on the fourth day. This is commonly seen in Plasmodium malaria. Normally, we don't really get to see these patterns of fevers anymore because of the use of over-the-counter antipyretics that the patient usually takes themselves. We also have a few other named patterns which are associated with a particular disease. So we have a continuous step ladder pattern of fever. Can anyone tell me which disease is this commonly seen in? Typhoid fever, exactly. So this is one that has a gradual increase before when we start therapy, and then with a gradual decrease in the temperature. Then we have Pell-Epstein virus. Which disease is that associated with? Hodgkin's lymphoma, exactly. So this is also another type of cyclical fever which occurs, which has a febrile period of about 3 to 10 days, followed by an afebrile period of the same amount of length. Then we have an undulant fever, which is a wave-like fever. Which disease is this commonly seen in? Brucellosis, exactly. So this is a relapsing, remitting type of fever that has a wave-like pattern. Now I'd like to move on to the medical causes of fever. These can be broadly classified into 5 headings, that being infectious, non-infectious inflammatory, neoplasms, thermoregulatory disorders, and miscellaneous causes. So in infections, we can have bacterial non-specific causes of fever, that being UTI, PID, pneumonia that we commonly see in our OPD patients. Then we have specific bacterial infections such as tuberculosis, rickettsia, salmonella, which can cause fever. Fungal infections, aspergillosis, candidiasis can also cause fever. Parasitic diseases, malaria, amoebiasis that are commonly seen, and viral such as HIV, dengue, cytomegalovirus. Then we have non-infectious inflammatory diseases such as systemic rheumatic and autoimmune diseases. Rheumatoid arthritis, SLE are commonly present with fever in our OPDs. Vasculitis such as granulomatosis with polyangiitis, Churg-Strauss syndrome. Granulomatous disease such as sarcoid can also present with fever. And autoinflammatory syndromes such as Crohn's disease also have certain predilection with fever. Then we have neoplasms. Hodgkin's lymphoma, as we've already discussed, presents with Pell-Epstein type of virus. Leukemias, breast and colon carcinomas among solid tumors are commonly associated with fever, and Castleman's disease. Then we have thermoregulatory disorders, which can be central or peripheral. As mentioned earlier, cerebrovascular accidents, hemorrhages can cause central hyperthermia, and peripheral causes include exercise-induced hyperthermia and pheochromocytoma. Miscellaneous causes include drug fever, hypersensitivity reactions. Now I'd like to call on Dr. Rachna from the Department of Microbiology to take this discussion on fever further. Thank you.
Good morning, respected teachers, seniors, and my dear colleagues. So till now we already have discussed about the physiology, types and causes of fever. I'm taking this discussion forward by telling about the various microbiological tests and their uses to either confirm or to rule out the infectious causes of fever. So either to confirm or to rule out the infectious causes in particular, we need right test within right time by right methods. And all these 3 R's are confirmed by 5 components, or are covered under 5 components. They are ordering right test, collecting right sample, performing reliable and accurate tests, reporting the right interpretation, and communicate the report at right time. Out of which the first 2 components comes under depends upon the clinician approach towards the patient according to their sign and symptom, or the area in which that disease is prominent or endemic, or particular season is specific, like in monsoonal or post-monsoonal season, etc., to reach at some probable differential diagnosis. And collecting right sample means if they are suspecting UTIs, then they should send urine sample. If it is meningitis, CSF sample will be more accurate. Then rest 3 components, performing reliable test, reporting right interpretation, and communicating the right report, comes under microbiological components. So now I will start with different tests in microbiology done to rule out or rule in the infectious causes. First one is serological or immunological tests, which means In this, we identify or calculate the antibodies or antigen titer in different samples like urine, blood, body fluid, etc. And they are done for different etiological agents like bacteria, virus, fungal or parasites. These are name of some of the specific tests which we perform. Most common of them are like Vidal, MT test, various skin tests. Then for virus, we have markers like HIV virus, viral marker rapid test. For fungus, we have cryptococcal capsular antigen test. For parasitic infections, we have rapid malaria kit, trias parasite panels, in which we detect 3 parasites on a single rapid test. Then we have advanced serological test, which includes CLIA, that is chemoluminescence immunoassay, Chorus, ELISA, etc. Why they are advanced? Because initial serological test gives us only the qualitative result, like in form of reactive or non-reactive or positive, negative, but we don't get the exact numbers. But the advanced serological test gives us the semi-quantitative results, which means they gives us a range of antigen or antibodies, or they gives us a quantitative measurement of antibodies. For example, in case of HIV, if the result comes indeterminate in initial test, then we confirm it by CLIA. Then we have test for biomarkers. For fungus, we have Mannan 1,3 beta-D glucan galactomannan test. Then we have test for inflammatory markers like CRP, procalcitonin, interleukin, tumor necrosis factor, WBC with ESR. These are the naturally occurring biological molecules present in body, and their variation from the normal range gives us an idea about the ongoing pathologies. Then we have advanced molecular tests, which consist of polymerase chain reaction tests, which are done for various infectious diseases like COVID virus, CMV, EPV, hepatitis A virus, etc. Then we have multiplex PCR panel, which they are also a type of PCR, but in this we can detect more than one organism or one target from a single cartilage. For example, we have pneumonia panel, meningitis panel, encephalitis panel, then tropical fever panel, influenza panel, etc. Then we have cartridge-based nucleic acid amplification test, CBNAT, which is done for mycobacterium detection with rifampicin resistance. Then we have expert RIF Ultra, which is also a type of advanced form of CBNAT, which is used for paucibacillary tuberculosis or extrapulmonary tuberculosis, which can detect a very minimum number of bacteria present in the sample, and also they can detect the resistance against the second line and other IV injectable drugs used in tuberculosis. Then the most common test which we perform in microbiology is the microscopy, and it covers 2 types of mount preparation. One is the wet mount. Wet mount means we make smear directly from the sample, and we do the basic identification of the organism, that is the causative agent is either bacteria or fungus or any parasitic causative agent is there. And this wet mount is helpful in putting on the culture which we perform later on. Then second one is smear staining, in which we stain the smear from the sample using different type of stains according to the organism. Most common, we all have heard these names: Grams, Zeden staining, Pass, Grocott, these are for fungus. Then modern trichome stain and Romanowski, these are for parasitic infections. These are some of the pictures of common staining techniques like gram staining, where we detect gram positive and gram negative bacteria. Then we have Zeden staining to differentiate ABs, and then chalcofluorescence staining is in which we see fungus under fluorescent microscopes. Then the most common, and everybody know this name, culture and sensitivity, we do in department. It consists of 2 parts, culture and sensitivity. What culture means? Culture means growing the organism, because in some sample their amount is very much less, and we can't put those amount of organism to get the sensitivity pattern. That's why we grow the organism on their desired agars or their nutrients. There are different type of cultures we use, like aerobic culture medias, then anaerobic culture media, then we have fungal culture medias, we have mycobacterium culture medias. These are pictures of some of the common culture media which we use in our lab. This is the growth of mycobacterium. On first picture, the green one is conventional media, which is LJ media. Then second one is the MISIT, which is automated system. These all are done for mycobacterium tuberculosis. Then comes the second part, AST or antibiotic susceptibility testing. After we get the growth, we proceed for species level identification and drug susceptibility test, which we can do manually by using Kirby board or by automated system like Vitek2 and MALDI-TOF. These are based on different principle to identify the drug concentration on which that organism will or those drug will act on those organism. Vitek2 gives us the identification as well as the sensitivity pattern. These are the report which we get from the automated Vitek2 system. Here we can see the name of sample and the or isolate which we obtained from that sample, and these are the drugs which we have put in the machine, automated machine, and the reporting is in form of MIC values, and then there is an interpretation. So what is MIC? MIC is the lowest concentration of any microbiological antimicrobial agents that will inhibit the visible growth of organism, and clinically it is used to determine the amount of antibiotics that patient will receive as well as the type of antibiotic use. And the interpretation in form of resistance, intermediate or sensitive is determined by the breakpoints. Breakpoints are mainly the cutoff value for MIC for every organism, for every drug, and it is predetermined by universal organizations like CLSI and UCAST in our microbiology, and they fix it for every organism, for every drug, and we compare that with our MIC which we get from the machine, and we give this interpretation. That's all from microbiological part, microbiology segment. Now I will call Dr. Swati Rathod to take the discussion further. Thank you.
Good morning, everyone. Today I'll be discussing the different diagnostic modalities in pathology that aid in the diagnosis of fever. The first is hematology, in which on a complete blood count, sepsis presents as neutrophilic leukocytosis with toxic changes, and hypereosinophilic syndrome presents as eosinophilia. On a peripheral blood film, malaria and leukemia can be diagnosed. On bone marrow examination, leishmaniasis as LD body and leukemia. The second is clinical pathology, in which on urine examination, one of the most common causes of fever, UTI, can be diagnosed. The third is cytology, in which on a fine needle aspiration cytology, TB and malignancies can be diagnosed. Then in fluid cytology, on a CSF, meningitis, and on other fluids such as peritoneal or pericardial malignancies can be ruled out. The fourth is histopathology. On H&E, all the benign and malignant causes of fever can be diagnosed. On special stains such as for TB we have Zn stain, and for fungal causes we have PAS or GMS stain. The last is ancillary test, in which IHC is used to rule out all the malignant causes of fever. Here are some hematological reports. The normal WBC count is 4 to 10,000 and the normal neutrophil count is 2 to 7,000. In the complete blood count image, we can see that there is neutrophilic leukocytosis. Both the WBC and the neutrophil count has increased. And the same is represented on the peripheral blood film, where we can see increased number of neutrophils as neutrophilia. And these neutrophils have increased number of granularity, and those granules have become coased and they are called as toxic granules. This image represents a sepsis. The next is a eosinophilia, in which we can see increased number of eosinophils. Now tuberculosis can be diagnosed on a FNSE as we can see a granuloma formation and epithelioid cells. Then on an H&E, we see over here a central necrosis, a granuloma formation, epithelioid cells and Langerhans giant cells. They are also called as horseshoe shape because the nuclei is arranged on the periphery. Then the special stain for TB is Zn stain for the AFB, in which it appears as red colored rod shaped bacilli. Now parasitic infection. Malaria on PBF, we can see the ring shaped trophozoites of Plasmodium falciparum. And amoebiasis on H&E is caused by Entamoeba histolytica, and we can see a flask-shaped ulcer in submucosa where the base is broader than the apex and the base consists of cellular debris. Fungal infection. Aspergillosis caused by Aspergillus species. On a GMS stain, we can see highlights of acute branching fungal organisms. Cryptococcus. On PAS stain, we can see encapsulated variably sized yeast with thin wall. Leukemia. On a PBF and bone marrow examination, we see lymphoblast which have increased in size. The nucleus is round to oval. We can see 2 to 3 prominent nucleoli, and there is immature chromatin, and there is scant to moderate amount of cytoplasm. Lymphoproliferative disorders. There are 2 types of lymphoma, Hodgkin's lymphoma and non-Hodgkin's lymphoma. The diagnostic characteristic of Hodgkin's lymphoma is a RS cell or the Reed-Sternberg cell, which is binucleated with a prominent nucleoli and dense amount of eosinophilic granular cytoplasm. And in non-Hodgkin's lymphoma, we can see pleomorphic anaplastic large B cells. Now, I would like to invite Dr. Apurv Khandelwal to discuss the surgical perspective on fever.
Good morning everyone. I am here to give you a surgical point of view on fever. So in every OPD, fever is a complaint, but in surgery ward, it is an associated complaint or complication of disease of procedure. So let's begin a story of Mr. X who was too hot for a surgeon's comfort. This is Mr. X showing most common causes of fever in surgical OPD like liver abscess, cholangitis, abdominal TB, appendicitis, pyelonephritis, pancreatitis, cystitis and perineal abscess and many more. So let's begin with the first disease, that is liver abscess. So the patient comes with a complaint of pain in the right hypochondrium and fever with chills and rigor. The major investigation that can be done is complete blood count, sonography and contrast enhanced CT. The treatment can be done by drainage of the abscess, that can be done by USG guided drainage or laparoscopic or open drainage with drain in situ. The next disease is appendicitis. The patient present with Murphy's triad, that is pain in the right iliac fossa, vomiting and fever. The investigation of choice can be total leukocyte count, sonography and contrast enhanced CT. The treatment can be done by laparoscopic or open appendicectomy. The next cause is cholangitis, that the patient presents with Charcot's triad, that is intermittent fever, intermittent pain in the right hypochondrium and intermittent jaundice. The investigation of choice will be LFT and magnetic resonance cholangiopancreatography. The treatment of choice can be done by medical management of the patient. Then the next disease is abdominal TB. The patient present with evening rise of temperature, generalized pain abdomen and weight loss. The investigation of choice is contrast enhanced CT and it can be confirmed by colonoscopy and biopsy. The treatment of choice will be ATT, that is anti-tubercular drugs, and if indicated then we can go for laparotomy and proceed. The next cause will be portal pyemia. The patient comes with abdominal pain and fever. It is the most common complication of appendicitis, and investigation of choice is CCT triple phase. The treatment can be done by medical management. The next cause that is most common in surgical OPD is perineal abscesses. That the clinical feature will be fever with chills and pain in the perineal region. The investigation of choice is sonography, soft tissue and MRI perineal region if we are finding any fistulous tract. The treatment can be done by incision and drainage of the abscess. The other surgical causes like pyelonephritis, nephrosis and cystitis have a very similar clinical features, that are fever with increased frequency and burning maturation associated with hematuria. The investigation of choice will be urine routine and culture and sonography of whole abdomen. The treatment will be lots of liquid and it can be managed medically. These were the surgical causes of fever. Moving to post-operative causes of fever. Like in Bollywood movie Dhamal, the actor were finding big W's. Likewise, we also need to search W for post-operative cause of fever. So these are the 5 W's of post-operative fever. First will be wind, that represents lungs. So the cause of fever will be atelectasis with superadded infections. It is the most common cause of fever on the post-operative day 1 and 2. The prevention can be done by incentive spirometry and cessation of smoking 1 week before and after the surgery. The second W is water, which represents urinary tract infections and superficial thrombophlebitis. It is the most common cause of fever on post-operative day 2 and 3. It can be prevented by lots of liquids, IV cannula and catheter care, and early removal of Foley's catheter. The third W will be lack of walking, which represents deep vein thrombosis. It is the most common cause of fever on post-operative day 4 and 5. The prevention can be done by early mobilization and DVT prophylaxis. The fourth W is wound, that includes surgical site infections and intra-abdominal abscesses. The most common cause of fever of post-operative day 5 and 7. Prevention can be done by proper hand hygiene, part preparation, maintaining sterility and prophylactic antibiotics. The last W is wonder drugs that includes adverse drug reactions and allergic reactions. It is mainly diagnosed by excluding the other causes, and patch test to evaluate delayed hypersensitivity can be a preventive measure. Let's go to the next slide. I invite Dr. Anupriya to take this discussion further. Thank you.
Good morning everyone. Taking the presentation forward, I am here to discuss about fever and pregnancy. So maternal mortality due to fever in pregnancy varies from 1.8 to 5.9 per 1 lakh deliveries. Even if all the fevers are not infectious, it is mandatory to know about the infectious cause to conclude about the effects on the mother and the second patient, that is the fetus. So the effects on fetus in early pregnancy might range from abortion, low birth weight to small for gestational age. Basically, the signs and symptoms in the early pregnancy masks the warning sign. But if affected, it disrupts the organogenesis. Similarly, later in pregnancy, the physiological changes make the assessment of severity difficult. But if affected, it might affect the neurological impairment or growth disturbances in the fetus. It might also cause intrauterine growth retardation, oligohydramnios, meconium strain amniotic fluid with fetal distress, and preterm labor. So the clinical approach for a pregnant female presenting with fever goes similar to a non-pregnant female, where, for example, a patient complaining of rupture of membranes with increase in temperature, that is more than 37.8 degrees Celsius. On examination, we get maternal tachycardia, uterine tenderness, fetal tachycardia, malodorous amniotic fluid, and on investigations, peripheral leukocytosis with no other apparent signs of infections. We need to categorize the female into a systemic infection and an intraamniotic infection, that is the obstetric causes. So dealing with the obstetric causes of fever in pregnancy, the first and the foremost is the urinary tract infection. The patient presents with fever, dysuria, and frequency. Next, we have the chorioamnionitis, wherein a pregnant female will present with fever, maternal and fetal tachycardia, uterine tenderness, purulent or foul-smelling discharge. It is managed by serial monitoring of C-reactive protein, complete blood count, high vaginal swab. A combination of antibiotics is prescribed until delivery, and early termination is advised if indicated. A very rare obstetric cause of fever in pregnancy is acute pyelonephritis that is found in less than 2% of the patients. Next, we have puerperal pyrexia, which is one of the top 5 causes of maternal deaths worldwide. It is defined as a temperature reaching 38 degrees Celsius, excluding the first 24 hours and within the first 10 days following delivery. The approach remains the same. History, including time of delivery, type, length of labor, any complications following delivery, and any relevant past medical or antenatal complication. Physical examination that includes the vitals, the examination of the breast and the legs, inspection of the surgical site, palpation of the uterus for the size and tenderness, and a sterile speculum and bimanual examination, followed by investigations that includes high vaginal swab, complete blood count, urine culture and microscopy, and ultrasound. So, the first and foremost again goes, the presentation goes with dysuria and burning maturation, fever with chills, suprapubic pain, increased frequency and urgency. We need to rule out urinary tract infection. Next, a patient presenting with cracked nipples, fever with chills and rigor, pain, inflammation, and on examination hard and tender breasts. We need to rule out breast engorgement, inflammation, or breast abscess. The treatment varies from expression of breast milk in case of engorgement, antibiotic therapy in case of inflammation, and incision and drainage is advised in case of breast abscess. Any infection of the episiotomy site or the cesarean scar, the patient presents with fever, which is either persistent or appears after the day 4th. The site is warm and there is pain, and it is painful. The wound may be erythematous with pus discharge. Next, we have a patient presenting with fever, uterine and parametrial tenderness, bleeding, offensive odor or foul-smelling discharge. We need to rule out metritis. And in case the fever persists after antibiotic therapy or the pain persists, a sequel, that is septic pelvic thrombophlebitis, need to be ruled out. Now we have a patient presenting with history of pregnancy, abortion, fever and tachycardia, purulent vaginal discharge, and lower abdominal pain and tenderness. We need to rule out septic abortion. I now call upon Mahima to go ahead with the approach of fever.
Let's get to the approach to a patient with fever presenting to us. First and the foremost is the history and the physical examination. That includes the chronology of the events preceding fever, that includes fever pattern, duration of fever, any previous medical history, present and recent drug use, family history, measurement of the temperature, and the same site should be used consistently to monitor a febrile disease. Active disease can be present even in the absence of fever, and such is seen in extreme of ages, patients with chronic hepatic or renal failure, patients taking glucocorticoids, patients treated with anticytokines. The laboratory investigations include the complete blood count, C-reactive protein, ESR, IL-6, and the specific investigations. The acute fever can be classified into three categories, that is acute undifferentiated febrile illness, acute febrile illness due to localized infections, and fever of unknown origin. Acute undifferentiated febrile illness is defined as the acute onset of fever of more than 101 degree Fahrenheit for more than 2 days without organ or system specific signs at the onset. The acute febrile illness due to localized infections can be due to respiratory tract infections, urinary tract infections, intra-abdominal infections, and fever of unknown origin is defined as the fever of more than 101 degree Fahrenheit for more than 21 days that remains undiagnosed even after a hospital workup. Coming to acute undifferentiated febrile illness. It has history of no localizing symptoms except accompaniments such as chills, headaches, retroorbital pain, myalgia, malaise, nausea, vomiting. Anybody would like to think about the DDs of such a patient? The DDs that can be thought in such a patient can include malaria, dengue, enteric fever, chikungunya. The approach to a patient with acute undifferentiated febrile illness includes evaluation of the medical history, thorough clinical examination of the patient, assessment of the clinical signs and the complication, confirmatory tests, and the treatment options. The red flags in a patient with acute undifferentiated febrile illness include difficulty in walking or sitting, hyperpyrexia or hypothermia or rigors, the shortness of breath with decreased saturation, decreased blood pressure, cold clammy extremities, altered sensorium, behavior changes, convulsions, abdominal pain, hematemesis, and melena. Now let's come to a patient that presents to us in the OPD with fever with low grade, with evening rise of temperature, night sweats, weight loss, decreased appetite, cough with or without expectoration. What could be thought for such a patient? Anybody would like to answer? Tuberculosis can be thought for such a patient. The patient presenting with fever, with cough, with or without expectoration, shortness of breath, chest pain, chills and rigor, and or severe malaise, the lower respiratory tract can be thought to be involved in such a patient. Coming to patient with fever, with dysuria, increased frequency and urgency, with or without chills, flank pain, acute cystitis or pyelonephritis. Fever with pain in abdomen, nausea, vomiting, diarrhea, tenesmus, per rectal bleed, intra-abdominal infections can be thought. Fever which is high grade, acute onset, tender swollen joints, the bone and the joint infections such as the rheumatoid arthritis can be thought, or the septic arthritis. Fever which is rapid progression of lesions, bulle, rapidly intensifying pain, redness, lymphadenopathy, skin and soft tissue infections. Now let's think about the DDs for a patient that presents to us with fever with rash. Anybody would like to answer? Coming to an approach to fever of unknown origin. Detailed history and physical examination with careful attention to the skin, lymph nodes, medication history, travel, dietary exposure is required. We need to confirm that the patient does have fever, and we should withhold the antibiotics if the patient is stable and there is no neutropenia. Second is we need to determine whether the patient requires hospitalization or does not require. Next is the minimal investigation, battery of investigations that need to be done to rule out the initial infectious causes, and the advanced investigations which will be based on the patient's history, physical examination, epidemiology. On this,
what is the importance of travel history?
So certain diseases are prevalent in certain parts of the country. In our country also, like in Bihar, like Kala Azar. So such travel history or animal contact can be present in such cryptococcus histoplasmosis that needs to be ruled out for such patients.
So that is within the country. Anything else?
Sir, initially COVID was there when the patient's travel was to, and
But the proportion which COVID assumed, you didn't require to travel to any place to get it.
so initially it was
What about international travel?
yellow fever.
So there are certain diseases which are more prevalent or they are not seen in our country. And actually travel history started with people from the Western world coming to underdeveloped and developed countries because of water, sanitation, hygiene and all.
Yes, sir.
So it's more important in that way rather than for us. We don't need to travel anywhere to get a bacterial or a protozoal infection.
Yes. So on this basis, either the diagnosis is made or the diagnosis is not made. If the diagnosis is made, we need to test accordingly and consider an empirical course of the antibiotics for the patient. If no diagnosis is made, we need to revisit the clinical status and the patient's history, and we need to consider factitious fever. If the fever has not self-resolved, and we need to perform additional tests based on newly emerged symptoms, and we can go for a PET scan for the patient if not done. On this, either the diagnosis is made or still not made, and we need to keep the patient under watchful waiting and give reassurance to the patient. So to end the presentation with a take-home message that appropriately obtained temperature should prompt clinician to take appropriate diagnostic tests. Fever has no one-to-one relation with infections, and we need to consider all possibilities and take multidisciplinary approach. Appropriate laboratory and imaging should be performed, and there should be a judicious use of the antibiotics.